The management of hypertrophic cardiomyopathy has evolved significantly, shifting from purely symptomatic relief to a comprehensive strategy focused on sudden cardiac death prevention and specialized interventions for outflow tract obstruction. Medical management is still the first line. The primary goal is to improve diastolic filling and reduce pressure gradient across the left ventricular outflow tract. Beta blockers are the cornerstone of therapy, like metoprolol and atenolol. They decrease heart rate, increase diastolic filling time, and reduce inotropic response. Calcium channel blockers, non-dihydropyridines like verapamil, are used if beta blockers are poorly tolerated or ineffective. Avoid in patients with severe resting obstruction or heart failure. Disopyramide, an antiarrhythmic with negative inotropic effects, often added to beta blockers to further reduce LVOT gradients. Mavacamten, a newer first-in-class cardiac myosin inhibitor, specifically approved for symptomatic obstructive hypertrophic cardiomyopathy. Sudden cardiac death risk stratification. All patients must be assessed for an implantable cardioverter defibrillator based on prior cardiac arrest or sustained ventricular tachycardia, family history of premature HCM related death, massive left ventricular hypertrophy, wall thickness 30 mm or more, unexplained syncope, apical aneurysms or left ventricular ejection fraction below 50%. Genetic testing is a class 1 recommendation for patients with a clinical diagnosis of hypertrophic cardiomyopathy. It serves two primary purposes. One, etiological clarification, identifying HCM mimics such as Fabry's disease, Friedreich's ataxia, or ATTR amyloidosis, which require entirely different treatment pathways. Cascade screening. Once a pathogenic variant is found in the proband, that is the affected person, first-degree relatives can be tested. Genotype negative relatives can generally be discharged from regular clinical surveillance. Genotype positive relatives require longitudinal monitoring with ECG and echo, even if currently asymptomatic. Most mutations occur in the cardiac sarcomere, specifically MYH7, that is beta-myosin heavy chain, and MYBPC3, myosin binding protein C. Alcohol septal ablation is a percutaneous, that is non-surgical intervention for patients with obstructive hypertrophic cardiomyopathy who remain symptomatic despite optimal medical therapy. A tiny amount of absolute ethanol, 95 to 98%, is injected into a specific septal perforator artery after distal blocking with a balloon. It's a controlled infarction. The alcohol causes a localized planned myocardial infarction of the basal septum. The infarcted tissue thins and scars over time, widening the LVOT and reducing the pressure gradient and mitral valve systolic anterior motion or SAM. Here is a comparison between alcohol septal ablation and septal myectomy, that is surgical. Invasiveness, minimally invasive catheter based for alcohol septal ablation, while septal myectomy is open heart surgery. Naturally, recovery is shorter hospital stay for septal ablation and longer recovery period for septal myectomy. Common risk for alcohol septal ablation is need for permanent pacemaker due to complete heart block. The risk is lesser with septal myectomy. Effectiveness alcohol septal ablation is highly effective. Results depend on vascular anatomy. Septal myectomy is the gold standard for long-term relief. Alcohol septal ablation is generally preferred for older patients or those with significant comorbidities, whereas myectomy is often favored for younger patients or those with concomitant mitral valve disease.